Hello, everybody, and welcome to the lecture on bipolar affective disorder. What this lecture aims to cover is to introduce you to the classification of mood disorders. We will be discussing the clinical features and the etiology of bipolar affective disorder, and we will be discussing the principles of management of bipolar affective disorder. These principles of management you can also use in managing patients with other mental health conditions as well. Okay, I hope you're familiar with the mental state examination, and different disorders show pathologies in different components in the mental state examination. And since bipolar affective disorder is a disorder of mood, one of the most important um, pathologies you would see in your mental state examination is a disruption of mood. But you will also see changes in the other components of the mental state examination in a patient with bipolar disorder, which we will be discussing later. Okay, so there are different types of mood, which was probably introduced to you earlier. Euthymic mood is sometimes what we call normal mood. And when you say normal mood, that is to say that a person with normal mood is able to experience a full range of emotions, or the full range of mood. He can feel sad, he can feel happy, at times he might feel angry. But if they do experience these types of modes, it is the intensity and the frequency or the duration that makes it pathological. So if you're feeling dysphoric or sad, and you're feeling it very intensely, and you're feeling it for a prolonged period of time, then that is an abnormality of mood. Or if you're feeling happy, but you're feeling extremely happy, euphoric or intensely happy, and you're feeling intensely happy for a long period of time, then this is a pathology in mood. So euthymic mood is where you're able to feel the full range of emotions. You're able to experience the different types of mood, but it's not to that intensity or to that duration where it becomes abnormal. Okay. So based on that, we classify mood disorders into the two different arms, which is unipolar depression, where you experience intense sadness for a prolonged period of time, and bipolar affective disorder, which is what this lecture is based on, where you experience intense sadness for a prolonged period of time, followed by probably a period of recovery. And you also are able to, you also have periods where you feel extremely happy or extremely irritable for a prolonged period of time. So unipolar depression is where you have only depression, and you might have repeated episodes throughout the lifetime of a patient. In bipolar affective disorder, you have two poles. So it's unlike in unipolar where you have only depression. In bipolar disorder, you can have periods of depression as well as periods of mania, which we will discuss. Okay, so with regard to the classification of mood disorders, ICD-10 recognizes 4 different types of mood disorders. You need to be familiar with this. ICD-10 describes what a manic episode is, and we'll be discussing that later. So a manic episode is where you only experience a period of mania once. So if you meet a patient who has had a period of mania, then that patient, we say that that patient has suffered a manic episode, and that's it. And he probably has never experienced any abnormalities in mood thereafter. That is quite rare, but we do come across patients like that. Then the second classification is bipolar affective disorder, where the patient has experienced periods of depression, and then periods where he has been fine, he has been doing well, no periods of depression or mania, and then he develops this episode of mania. So this baseline is to show you that this is euthymic mode, and this dip is the depression, and this upward, the triangle on top is a manic episode. So if a patient experiences depression and mania, or mania followed by depression, then this patient is experiencing two polarities. And we say that this patient can be diagnosed with bipolar affective disorder. A depressive disorder is similar to a manic episode, where you have, in the patient's lifetime so far, he has had only one episode of depression. So we classify that patient as having a depressive disorder. If this patient goes on to develop more depressive episodes in the future, then we would diagnose this patient as having a recurrent depressive disorder. So he has had many depressive episodes throughout his lifetime, which is probably the more common variety. Okay, so just to sum up, bipolar disorder is where patients have episodes of depression and episodes of mania. And in between, majority of patients experience normality or normal mode or euthymic mode. Okay, so let's discuss the central features or the main features of a manic episode. You need to know this in order to recognize a manic episode in a patient, or to understand that this patient is currently in a manic episode. So the key features are, you need to show the abnormality in mood. So in a manic episode, the patient has to be either experiencing elevation of mood, that is extreme euphoria or extreme happiness, or the patient has to be having an irritable mood. These patients have self-important ideas. They have a lot of self-esteem, self-confidence, and think very highly of themselves. So if you talk to them and you explore their thoughts, their thinking, they will come out with all these very self-important and very self-confident type of ideas. And these patients have a very high level of energy, and they will be overactive or extremely energetic. So if we are to classify manic episodes, we can classify manic episodes depending on the severity of the manic episode. And the ICD-10 again describes 3 degrees of a manic episode depending on the severity. The first is a hypomania, and as the name implies, it means mania, but not as severe. So if you do have a patient who is having elevated mood, is very energetic, has a lot of self-expansive ideas, but he's still able to function normally, he's still able to continue working, still able to maintain relationships and go on with his daily routines, and does not require hospital admission, then we would say that this patient is in a hypomanic episode. The next degree is a manic episode, where we discussed earlier, where the patient is extremely energetic, is euphoric, and most probably requires hospital admission. Then we would say that this patient is in a manic episode. And the next degree, the third degree, is where we say a patient is having mania with psychotic symptoms. So without psychotic symptoms is considered of a lesser severity, and patients with psychotic symptoms are considered to be in a very severe, experiencing a very severe form of mania. So having psychotic symptoms superadded on a manic episodes is considered a very severe episode of mania. So these are the 3 degrees identified by the ICD-10 on a manic episode, and it is classified on the severity of the manic episode. Right, so how will a manic or hypomanic patient present to you? Like I said, so it's a disorder in mood. So the patient will say that he's feeling extremely happy, or yeah, the relatives might complain that he's very irritable these days. So he's either experiencing happiness, extreme happiness, or severe irritability. You would find these patients either laughing or singing or being very overactive, and you might actually find it very difficult to communicate with these patients. They are dressed in bright clothes. They wear, some of them might present you wearing lots of jewelry, a lot of makeup, overdone makeup, very ornate. Some of them might be sexually disinhibited. They might exhibit inappropriate behavior, and all this might be, you might find it very difficult to communicate, or to communicate with these patients. um, these patients are very vocal. They'll be talking very rapidly, talking very fast, and there'll be lots of words if you count, if you give them a minute. So the number of words spoken per minute will be very high. So we call that pressure of speech, and they might be very loud. The majority of them are very loud. If you go, they will start expressing ideas of grandiosity, ideas of self-importance. Some of them who are probably psychotic might express to you that they have special powers, and that they are known to special people of importance, and that they themselves might be very special religious figures. If you are to examine a patient like this, so in your mental state examination, it has to be a very focused examination, because sometimes it's very difficult to perform a detailed examination on a patient who is very manic. Um, Not only because of the risks they pose, but also because it's very difficult to build a good rapport with them. So in your mental state examination, try and focus or try and look for these things. So in the appearance and behavior, the patient might come across as very disinhibited. He might make remarks, inappropriate remarks. The patient might, he or she might try to touch you. So there will be a lot of inappropriate behavior. They might be very overconfident. They might try to take over the interview, and um, try to appear very, very confident. A manic patient's speech, like as I explained earlier, will be, there'll be a lot of pressure of speech where he'll be talking a lot. And there'll be a lot of flight of ideas. This psychopathology, which was discussed earlier in your mental state examination. Um, and obviously, the mood will be either elevated or irritable. Some of these patients might even, the range of mood might be even, the mood might be very euphoric at the beginning, and suddenly he might start crying, or he might become irritable. And we call this a lability mood, where the mood is not stable, and the mood tends to fluctuate from irritability to euphoria to extreme sadness. So there is no consistency in mood. And like we explained earlier, if the patient is psychotic, then he might have delusions in the form of grandiosity, or even persecutory delusions. You can have any type of delusions in bipolar affective disorder, but these are the more common ones to look out for. Hallucinations are again common. The hallucinations might be voices telling him how special he is, or he might even have commanding hallucinations, asking him to do certain things, which again poses a lot of risks. This is something for you to go home, read up on, the cognitive deficits you see in a patient with manic episodes. But if you do think of a patient you did meet with a manic episode, probably one of the most striking things were that his attention and concentration was very poor. He was very distractible. He was distracted, and it was difficult for you to maintain a rapport. And one reason for that is probably because of impaired attention and concentration. Majority of these patients will have very poor insight. Some long-term patients do come with some insight. Patients with in an early relapse might have some insight, but patients with a full-blown manic episode will have very poor insight. Okay, so that is one polarity which we discussed, which was the manic pole or a manic episode. And in order for you to diagnose a patient as having a bipolar affective disorder, at some point in the timeline or in that patient's life, you need to show that he also suffered from the other pole, which is a depressive episode. Very rarely would you get a patient with multiple manic episodes with no depressive episodes in his lifetime, but that is possible. And if you do get a patient with multiple manic episodes, again, we classify that patient as having bipolar affective disorder. Because if you follow up these patients over their lifetime, you would see that eventually they might start developing depressive episodes in the future. So, in order to, the depressive episode in bipolar affective disorder is very similar to the depressive episodes you have had lectures on depression and recurrent depressive disorder. However, there are some interesting presentations or some interesting symptoms and signs we do see, which are very special to bipolar depression. These are not very specific, but are interesting, and which we will probably discuss when you come for your professorials. So for the moment, a depressive episode, to understand the clinical features of a depressive episode in bipolar affective disorder, go back to your depression lectures, and you might find these clinical features: depressed mood, negative thinking, lack of enjoyment, reduced energy, slowness. So almost or absolutely the opposite of a manic episode. So the opposite polarity. And you need to be familiar with the ICD-10 diagnostic features of depressive episodes. And like I mentioned before, it is the same for diagnosing a depressive episode in unipolar depression. Okay, there's a lot of input with regards to episode. So as the name implied, mixed means where you have both features of depression and mania in one episode, where the patient experiences um, probably a depressed mood or low mood, but also experiences overactivity or pressure of speech within the same episode. So, in the same episode, the patient experiences both features of depression and features of mania, and we call this a mixed episode. We see this now more commonly, and if a patient develops a mixed episode at some point in his life, again, we would classify this patient as having a bipolar affective disorder. So let's say you have a patient who has developed a depressed episode a few months ago, and now is coming to you with features of a mixed episode, then you would consider this patient as having bipolar affective disorder. Okay. Just like schizophrenia, probably autism, ADHD, there is a very strong genetic predisposition to develop bipolar affective disorder if you have a family member, a first degree family member with the disorder. So in monozygotic twins, the heritability is about 60 to 80%. So a strong family history is very indicative of the chances of developing bipolar affective disorder. So far to date, the strongest risk factor to develop bipolar affective disorder is genetics. There are some studies or some debates with regards to other etiological factors like the place of neurotransmitters, the place of monoamines like serotonin, norepinephrine, GABA. But so far, all that is still at a very experimental level, but we do know that these play a role in the development of the disease. So a bit different or a contrast to unipolar depression, where you would see more female adults being affected than male adults. In bipolar affective disorder, the sex ratio is almost similar. So males and females are equally affected. The onset um, uh, of the disorder again is a bit younger than in unipolar depression, where we see patients first experiencing their depressive episode in probably the mid 20s or early 20s. But in bipolar disorder, majority of these patients start experiencing their first episode much early on, probably in their late teens. Okay, so how do we assess or yes, so how do we assess a patient with bipolar affective disorder? This is probably one of the most important part of the lecture. Your a proper assessment will not only help you come to a good diagnosis, a correct diagnosis, but will also guide you and help you with managing a patient. In my opinion, there are 5 areas which you need to concentrate on when you meet a patient with bipolar affective disorder. Number one, is my diagnosis correct? Have I got all the information required to say that this patient indeed is having bipolar affective disorder, or is it, or is it something else? Have I performed a proper risk assessment? So we will discuss, uh, just like any other mental illness, a risk assessment is of primary importance in a disorder like this, because with bipolar, with both polarities, in manic episodes and depressed episodes, you start seeing a lot of risks, and patients endanger themselves as well as others during these episodes. Unfortunately, bipolar affective disorder is a relapsing and remitting illness, which means that if you follow these patients throughout their life course, you would see that they have frequent relapses, or they have relapses at some point in their life. And it is important that you, in your assessment, you try and identify the reasons or the cause or the triggers of these relapses. And by identifying them, you can probably minimize the number of relapses in the future, and also advise patients on how to manage their relapses. Um, the records of previous episodes are also very important, especially in planning out your management, but also to understand the severity of this patient's illness, as well as to as a prognostication factor as well. Um, just like any other mental illness, social support comes into play, and we'll discuss the role of why social support is important in a illness like this. Okay, so hopefully you are confident about diagnosing bipolar affective disorder. So all you need is a proper history to demonstrate that in the past, this patient has had either a depressed episode or a manic episode. And currently, what is this patient experiencing? So if the patient has had only one depressed episode in the past, and he's currently in a manic episode, then you can confidently diagnose this patient as having bipolar disorder. Or this patient might just come to you with or a patient with a known bipolar affective disorder can come to you, and he's now coming to you with either a relapse of mania or depression. So your psychiatric history is going to be very important in establishing the diagnosis. Your current mental state examination is going to be vital. So, a proper mental state examination is very important in order for you to confirm what his current relapse is. Is he in a current depressive relapse, or is he in a manic relapse? So the history is going to be important, but the history has to be supported by your mental state examination in order to determine what this patient's current status is. Is he in a manic relapse, or is he in a depressive relapse? Okay, so these are the important risks you would see, you would want to ask, or you would want to consider in a patient with bipolar affective disorder. Patients with in a manic relapse, because they have um, uh, a lot of self-confidence, a lot of self-importance, or they might be psychotic, thinking that they are multimillionaires, billionaires. They are the rich. He's the richest man on the planet, and because of poor judgment, there will be a lot of overspending. So these patients will probably have used up all their money, withdrawn a lot of money from the ATM machines, overspent on unnecessary items like jewelry, a lot of jewelry, purchased vehicles, etc. So a lot of overspending is a huge risk which we see in patients with mania. Some of these patients might be very disinhibited, in the sense might be sexually disinhibited, and and which can bring on a lot of issues for especially females. Teenage girls can become pregnant. People can make use of them. There might be sexual exploitation as a result of disinhibition. There's a whole huge social cost and stigma involved as a result of poor judgment, being disinhibited, overconfident. They might obviously not be the person they usually are, and if and performance at the workplace can be affected. They might start making lewd remarks to their colleagues and family members, and there's a huge social cost in patients in relapse. Uh, some patients might become very aggressive, and they might be very physical, be verbally abusive, as well as physically abusive. And there have been reports where patients have assaulted people with very grave consequences. Patients can be so overactive and energetic, and because again of poor judgment, they might find it. They might even think that it is not a necessity for them to eat or drink, and they themselves might not understand that they are physically exhausted. And some patients can even present to you with dehydration. So physical exhaustion is a risk. um, Again, patients can be very excessively confident, a lot of self-esteem, and might like thrills a lot. And a patient like this behind wheels can be very dangerous. These patients can present to you, or the police might bring to you a patient who has been speeding a lot, and on examination he might present to you as a manic episode, as a patient in a manic episode. So these are generally the risks you would see in a manic episode. Um, in the depressive phase, one of the biggest, or one of the most important risk assessments you need to do is to do a suicide risk assessment. There is evidence to say that suicidality is more common in bipolar depression than in unipolar depression. So if a patient comes to you in a depressive relapse or in a depressive episode, then you need to do a proper suicide risk assessment. Okay, in the assessment, the third most important thing is to find out the reasons for relapse, or what were the triggers for the current relapse. or why did this patient who has had probably a manic episode 3 years ago, has been doing well for the past 3 years, and is now presenting to me with another relapse. um, the commonest reasons we see is one of the commonest is discontinuation of medication. Remember, I told you that it is a relapsing and remitting illness, and the best evidence to say that in order for patients to remain well, they need to be on medication for quite a long time. And majority of these patients present with basically discontinuing their drugs. um, Psychological turmoil, psychological stress is another cause for relapse. Maybe this patient lost a loved one recently or lost a job, or there might be some interpersonal conflicts happening in the background, and um, um, this may have contributed to the relapse. Another common cause for relapses are sleep deprivation. Again, patients might say that they had a funeral and that they were breaking rest for a couple of days, and then this could be identified as a cause for the relapse. Substance abuse, again, is a very common cause of relapse. Always ask patients whether what substances they are using, what are the substances they are abusing, as these have been identified as very common causes for relapse. In your assessment, it is important to ask about the previous episodes. Not only will previous episodes tell you, well, give you a clue to the diagnosis, but it will also tell you the severity of this patient's illness. It can also tell you what sort of treatment modalities have helped in the past and what haven't, and what are the risks to look out for. If this is a patient who had repeated deliberate self-harm attempts in the past during his depressive episodes, then it is more likely that he might attempt something during this depressive episode. Or if this was a female who became very sexually disinhibited during her previous manic episodes, then during this manic relapse, it is likely that she might become sexually disinhibited, and you need to um, uh, start thinking of things to mitigate these risks. Okay, management of bipolar affective disorder, like your other mental illnesses, is, well, there are two broad ways of managing it: pharmacological and there is psychological. Pharmacological is by far the most effective and recommended form of treatment, but there is good evidence to say that pharmacological management, coupled with a psychological intervention, brings out good results in patients, in order to make them better as well as to stay better. The choice of your pharmacological treatment will depend on the patient's current episode. So, is this patient currently in a depressive uh, uh, phase, or is this patient currently manic? So you need to first, in your assessment, you need to come to that diagnosis first. So this is a bipolar affective disorder patient currently in a depressed episode. After determining that, step two is for you to ascertain the severity of this current episode. So is this patient severely depressed with psychotic features and highly suicidal? Or this is a bipolar affective disorder patient currently in a manic episode with psychotic symptoms, with a lot of overspending and sexual disinhibition. So there are two steps. Number one is ascertain the current phase he is in. Is it depressed or manic? And then how severe is the current episode? That's how your pharmacological management will depend on. Psychological management is, I think we need to offer psychological management in some form to all patients. So general support, psychoeducation, alleviating myths, alleviating fears of family members is important. Educating the patient regarding drugs, side effects, all this is going to be important in the long-term management of the patient. There are also other specific psychotherapies that have been shown to be effective in patients with bipolar disorder. Remember, in a patient with severe mania, it is obviously impossible to start a very specific form of psychotherapy. For that case, even a patient in very severe in a patient with a very severe depressive episode, at that point, you might not be able to initiate psychotherapy. But once patients do recover and they are able to engage with you, then you could probably start thinking of very specific forms of psychotherapy. ECT is used in bipolar affective disorder. Again, your indications for ECT are the same indications you would use you used in managing a unipolar depression patient. So the indications would be the severity of the depressive episode. Is this patient very severely depressed, and is she not eating or drinking? Is the patient extremely suicidal? Something like that. ECT is also indicated in very, very severe mania, mania that has not responded to medication, mania with a huge amount of risks and which you're finding it very difficult to manage. In these cases of mania, again, ECT is indicated. Okay, so theoretically, if you take a patient with bipolar affective disorder, you might have three clusters in your management decision. That will depend on treating a patient in a manic episode. So the patient, you would say that this patient is in an acute manic episode if a patient comes to you currently in a manic phase. Or you would say this patient is currently depressed and I need to manage this patient for an acute depressive episode. Or you might even get a patient who is probably doing fine, has recovered from a manic or a depressive episode, and you need to make a decision on his long-term management. So which we say prophylaxis, or in order for him to, because we know that this is a relapsing illness, prophylaxis or long-term management is an important discussion you need to have with your patient and the family in order for the patient to remain well. So your pharmacological, there are different drug options that can be used in the pharmacological management of all these three types of management: acute mania, acute depression, and prophylaxis. And the combinations are, or the four different types of drugs are mood stabilizers, antipsychotics, antidepressants, and benzodiazepines. Generally, we tend to use a combination of these drugs, and a combination of all four of a combination of these drugs. These are the conventional or the classic mood stabilizers: lithium, sodium valproate, carbamazepine, and lamotrigine. So these are the conventional mood stabilizers. But we have now started talking about atypical antipsychotics, or even antipsychotics, as having mood stabilizing properties. So antipsychotics come in a different category, but it is important for you to understand that even though they come as an antipsychotic category, these drugs have mood stabilizing properties as well. So in an acute manic episode, you're able to use a mood stabilizer, and the commonest and the well-known and probably the most effective mood stabilizer we know to date is lithium. We can also use an antipsychotic where uh, generally drugs like haloperidol, olanzapine, risperidone have been shown to be effective in managing an acute manic episode. Or if you think this patient might benefit from a combination of these drugs, or the patient is extremely manic and is posing risks, you could use a combination of both a mood stabilizer and an antipsychotic. Sometimes patients might not respond to only a combination of mood stabilizers and antipsychotics, and you might have to throw in some benzodiazepines during the acute phase of the illness. Benzodiazepines also are known to have some acute manic properties, but it also helps with agitation and helps with sleep as well. Okay, acute depression. Probably one of the most important take-home messages that antidepressants as a monotherapy should not be given to a patient with an established bipolar disorder. It is always wise to use antidepressants in combination with a mood stabilizer. Because if you use only antidepressants in a patient with an established bipolar disorder and the patient is currently very depressed, you still run the risk of making this patient's mood very unstable, and eventually this patient might switch to a manic episode. So since bipolar patients have very unstable moods, adding an antidepressant without a mood stabilizer cover can further destabilize their mood and push them towards a manic episode. Therefore, if you are using an antidepressant, which is fine to treat a patient in a depressive episode, then always use it in combination with um, a mood stabilizer. A common combination that is used in the wards and which has a good evidence base is the combination of olanzapine and fluoxetine. So fluoxetine is the antidepressant that is used, and olanzapine, which is an atypical antipsychotic, is used as it has mood stabilizing properties. You could also use an atypical antipsychotic to treat a depressive episode. So it is not mandatory that you use an antidepressant to treat a depressive episode in bipolar depression. You could use just an atypical antipsychotic like quetiapine, which has a good evidence base again in treating bipolar depression. In the long-term prophylaxis, or in order for you to prevent further relapses in a patient, always see what worked for this patient during the relapse. And it is wise to continue this medication as your prophylaxis medication. However, there is a good evidence base to say that lithium is a very good prophylactic agent. And if you haven't used lithium in your acute phase of the illness, some clinicians do like to convert these patients onto lithium as long-term therapy. But again, that is at the discretion of the clinician and the patient. But I guess the take-home message is lithium is probably a commonly and widely and a very effective mood stabilizer to be used in the prophylaxis phase, in the prophylaxis of bipolar affective disorder. But you could also use drugs which worked for a patient during his acute phase as well. Okay, what are the non-pharmacological management options? As I explained earlier, education of the patient is of the illness, of the importance of medication is imperative. You need to tell the patient what sort of things might trigger these illnesses or what sort of things might cause the patient to have another relapse. Staying away from alcohol and substances is a discussion you might need to have with a patient who is probably abusing substances. Stress management skills, if this patient is a patient who things that stress triggers relapses, then you might have to introduce this patient to different stress management techniques. You will have to have the discussion of the importance of drug compliance. And there is a good evidence base to say that once patients stop taking their medication, there is a very high chance of relapse. A good sleep routine, introducing sleep hygiene techniques is going to be important. And not only the patient, but also educating the family of the early signs of relapse is going to be important. If the patient is able to catch the early signs of a depressive episode or a manic episode, and the patient can come to you for advice, then you're probably minimizing the risks of the patient having a full-blown relapse. Or there are maybe some patients who are able to adjust their medication by themselves when they identify early signs of relapse. So all these discussions you need to have with your patient prior to discharge. And as I mentioned earlier, there are different specific psychological therapies. You could introduce this patient to CBT during for bipolar depression has been found to be effective. Family-focused therapies, interpersonal and social rhythm therapies are some of the specific psychological therapies that have shown to be effective in bipolar disorder. Okay, so that concludes our lecture on bipolar affective disorder. There are some MCQs for you to try out when you're free. If you do have any questions or any queries regarding the lecture, please feel free to contact me. Thank you.